Hi, good evening, everyone. I'm Lynn Singer, Deputy Provost at Case Western Reserve University, and I'm very pleased to welcome you this evening to our program on substance abuse, confronting addiction in our community. As you all are aware and have been hearing in the news every day, heroin, opiate addiction have become really an epidemic in our time, affecting, as we heard last week, every suburb, every household in some way or another. So we are pleased that we can present this information to the public on behalf of the Melissa Ray Foundation, which has been created by Cheryl and Dennis Hirsch in honor of their daughter who succumbed to this addiction a few years ago, and we hope that you will think about that foundation and perhaps donate to it if you believe that this is an important issue. Last week we discussed medical-assisted treatment and kind of the overall issues related to heroin and opiate addiction in this community, and this week we're going to be talking about something that often people don't think about, which is the infants who are affected, pregnant women who are addicted to opiates or heroin and have babies, and what happens to those children. So that we'll be learning something new about that, because it's not often thought about. And I'm also pleased to introduce our moderator to you this evening, whom we're very, very lucky to have for all of these sessions, Vince Carafi, who's worked for the Cuyahoga County Board of Health for over 26 years, with the last 13 years as supervisor within the Environmental Health Division. Currently, he serves as the chair of the Cuyahoga County Opiate Task Force and partners with the Ohio Department of Health to address and stop this epidemic rise in opiate abuse within Cuyahoga County. And he's doing that by building partnerships, by educating the public, and by working with all of us. Thank you, Vince, for being here tonight and for doing this.
Thank you. Thank you again. Once again, I appreciate everybody taking the time to be out here on a subject matter that just seems to be daunting if you focus on, the news and the press. I would probably say over the last 12 months, we've seen this focus was on Cuyahoga County originally, but anybody that's paying attention to the papers, the introduction of fentanyl is impacting Hamilton County, Montgomery County, Franklin. So from a public health standpoint, when you focus on data, I think some of the things, the unexpected data that we've seen over the past couple years, I had the opportunity to work with Dr. Gilson, our medical examiner, and we used to do a poison death review where we took the time to sit around the table and actually review each fatality in Cuyahoga County to see if we could look at some opportunities for education or intervention. And we started this in 2012. And one of the striking things that has come out of this over the past couple of years is the rise in opioid abuse among women. It's something that was unexpected to me. One of the things that I just found recently, I'm actually working on a project with an individual that's in the crowd there looking at emergency room data for the number of people that present in Cuyahoga County. And it's shocking to see that out of the 1,800 people that have presented over the past 9 months, 40% of those individuals are women. So on our panel tonight, we're going to be talking about some of those things associated with that special population. The one thing that I really want to connect from our previous, our series last week is some of the words and the terminology that were used. We talked about stigma. We happen to see the importance of support networks for individuals that are in recovery, exclusively women. Those are some of the subject matters that we're going to be talking about tonight. We're going to do the same thing we did last week. If you have questions, I think Cheryl is going to go around and hand out note cards, and we'll pass those out, and we'll ask the questions for the whole panelists at the end of the presentation, if that works out well for people. So I'd like to introduce our panel. I'm just going to go over their names from the standpoint. I'll let them do the introductions. That worked out well, and unfortunately, I did turn 49 in early August, and I need these to actually read. So on our panel tonight is Dr. Jennifer Bailit. Dr. Bailit is the Clinical Director of Family Care at Metro Health Medical Center. I've had the opportunity to hear her speak several times, the great work that Metro is doing with this special population. And every time I speak to her, I happen to see her at the free clinic when Senator Portman was in town. And I actually try and do the best that I can to learn, what are some of the things that we need to address. And we had the opportunity to talk about hepatitis C and the impact that it's making in the population that we're going to be discussing tonight. Also on the panel is Dr. Philip Fragassi, Clinical Pediatric pediatric physician at Metro Health Center. He's also going to be talking about some of the challenges that are associated with substance abuse, with children, with mothers, and what we can do to actually change some of that. And then last is Dr. Sonia Minnes, Associate Professor of Social Work at the Mandel School of Applied Sciences at Case Western Reserve. And then we're also going to have a special guest that's going to speak to you on some of her experiences in regards to being in the program at that point in time. So I'm going to hand it off to Dr. Jennifer Bailit at this time, and the floor is yours.
Can you guys hear me through the mic? I'm going to take the speaker's liberty of sitting through this if you guys can hear me on the mic. So thank you everybody for coming today. I wear a lot of hats at Metro, but the hat I'm going to tell you about today is my clinical hat. I'm a maternal fetal medicine doctor by specialist by training. What that means is that I'm an OBGYN who has extra training in women who are sick during their pregnancies or babies who are sick during their pregnancies. And I've been at Metro for about 14 years. I will tell you that in 2002, when we first got there, we had about 7 women that first year who were addicted to opiates. Last year and this year, we're on track for about 180 women. And if you look at the graph of that, it's pretty much a straight line up. Pregnancy is a slightly different time in terms of treating opiates. We typically say a pregnant woman should not just stop taking opiates. She'll go into withdrawal, and when she goes into withdrawal, the baby goes into withdrawal, and that's not considered a healthy thing for the baby. And so rather than tell pregnant women to go what we call cold turkey or stopping suddenly, what we do is we put them on either, I guess you learned the term last week, MAT, we put them in either buprenorphine, otherwise known as Subutex or Suboxone, or methadone during the pregnancy. And that helps to even out the ups and downs that you get with heroin or pills and put the baby on a steadier state. There are lots of problems with being a heroin addict during pregnancy. The risks are somewhat maternal behavior driven, so things like the injecting of the drugs and getting abscesses anywhere on your body that you're injecting and leading to the bacteria coursing through your body can land in the placenta, can lead to preterm birth, can lead to the placenta coming off early, and even stillbirth. The other thing that happens is these babies don't grow very well. In a normal population, less than 10% of babies will be small. In our population, about 30 to 35% of our babies are small and requiring intervention or delivery early. These babies also tend to deliver early anyway. So then the question becomes, well, what happens to these babies after they're born? We tell women that 50% of the babies will have dependence on the medication and 50% won't. And what do we mean by dependence? This is an important point. A lot of people talk about addict babies. And that's really pejorative. What we're talking about when a baby has the umbilical cord cut and stops getting the infusion of heroin or whatever they're on, they will go through a physical withdrawal from the drug, at least 50% of the time. But they're not addicts in the sense of they're not having craving behaviors, they're not asking for drugs. I mean, obviously a baby can't ask, but they're not addicted in the way we think of an adult being addicted. They're not craving the drug, they're just physically withdrawing from the drug. And so we always use the word dependent rather than addiction when we're talking about newborns. So at Metro Health, we watch all babies for 7 days to see if they withdraw. If they don't withdraw at the end of 7 days, they can go home or to a foster care, depending on what's appropriate. And then if the babies do withdraw, we give little tiny baby doses of morphine by drops into the mouth and then wean them off slowly over about 3 or 4 weeks to try to get them in a healthier state where they can be off the medication completely. The question people often ask us is, what happens to our moms? We know that about 80% of our moms are, is that right? Yeah, 80% of our moms are clean at delivery, meaning that they don't have drugs in their system. So at least during pregnancy, we're having about a 70% success rate, 70 to 80% success rate. We know that 80% of our moms go home with their babies. Now, we call Children's Services on everyone. But Children's Services looks at the mom, looks at the family, looks to see how she's cleaning up or not cleaning up, or is she doing what we're asking. But at least around 80% of the time they're going home with the babies, which to us is a good sign that we're doing something right. That's probably better than most treatment programs for adults. Now, can I tell you long-term these moms are staying sober? can't always say that. We don't have the data to track them out, so I don't know the answer to that. For those of you who've had babies, you see your OB intensely for 9 months, you see them once more at 6 weeks afterwards, and then you drop off till your next pregnancy. So we don't see people continuously for healthcare, so we don't always know what happens. But I have had several people come back clean after several years and having their second and third baby with me having been clean now for years. So there are success stories out there. This is a recoverable disease. And I'll just add before I pass this on, I think, women will do things for their children that they wouldn't do for themselves, that they wouldn't do for another living soul on earth. And a lot of women, when they get pregnant, will do everything. They will move heaven and earth to get clean in a way that they just couldn't do before they were pregnant. That need to be a good mother and the shame of being a heroin addict when you're pregnant is very real. And once we can get past the shame and get people to say, look, nobody is the perfect mother, it's a matter of taking the next step and putting the next foot forward to do the right things, we get pretty good results. So I'll leave it at that. Monsi, do you want to come up? Monsi is the social worker at the Metro Health Program, and she's going to introduce our special guest.
Well, good evening. My name is Monsi. I'm one of the social workers. I had the privilege of working with Elizabeth. She's one of my all-stars, is how I call it. I met her last fall. At that point, she'd already sort of come in and done the entry work in the program. She was already clean and established on one of the MAT medications. So by the time I met her, what I noticed is she was extremely committed to her recovery. As Dr. Bailit mentioned, many of our moms, they really will do anything they have to get clean. And Elizabeth was certainly one of those moms. She really worked her butt off to focus on recovery. And what I noticed about her is that she's honest, she's committed, and she's normal. As we got to know each other, like many of the moms I work with, I noticed we have a lot in common. We had a lot of very typical new mom conversations. And so my tagline is always this: these are our sisters, these are our friends, these are our wives, these are our friends and neighbors. And that is what I saw in Elizabeth. And so I really commend her courage in coming out today to tell you a little bit about her experience. So please give her a warm welcome. This is Elizabeth.
My name's Elizabeth, and I'm a recovering alcoholic, and I'm not crying because I'm nervous. I'm crying because in October, I found out I was pregnant, October 23rd, 26th, something like that. And at the time, I was staying in a hotel room, prostituting, and using like 1.5 grams of dope a day, heroin a day. And I didn't know what to do. It was really weird. 2 days before I found out I was pregnant, I prayed to what I call God to die or go to prison because I couldn't stop. I had tried so many times to stop. And I found out I was pregnant. So I called somebody that I know had been through a similar situation, like the same situation. And she told me to go to Metro, be sick, and they would admit me and get me stabilized. So I came into Metro, and I was 6 weeks pregnant at the time. And I was really sick. And at the time, I didn't know whether I wanted to keep the baby, what exactly was going to happen. I have also lost a 12-year-old. He's now 12 during my addiction. And unfortunately, I couldn't get clean for him. But I have a relationship with him now. So through my pregnancy, I went to Metro. They got me on Subutex. I worked closely with Monsi, and I didn't work with Dr. Bailit. I worked with Dr. Gibson. And my baby was born. And throughout the whole pregnancy, my questions were, can I take my baby home? Is my baby going to be sick? And they couldn't tell me the answer to either one of those, unfortunately. So I just did as much research as I could and prayed. And my baby was born not underweight. He was born at 8 pounds, 6 ounces. And
It's a really good size.
Yeah. He didn't start getting sick until he was 2 days old. And seeing your baby go through withdrawal is the worst experience in my life. He was in the hospital for 3 weeks, And I will say that I know other women that had babies somewhere like in other hospitals. And Metro was really good to me. They actually moved my son up to the pediatric ward, and I don't know if it's because they were sick of seeing me in the nursery all the time, or they really cared and wanted me to stay with my baby. But I got to stay with my baby the whole 3 weeks that he was in the hospital. And Children's Services were obviously called, and they told me that there was no safety concerns, and my son's 3.5 months old. This is actually his pediatrician. And he's healthy and he's happy. And I'm going to be the success story because I am still clean. I work closely still with my doctor that prescribes my medication. I have no intention of coming off of it anytime soon because it's working for me right now. I don't know, that it was just, it's the most heartbreaking thing in the world. And it's crazy that 2 days before I found out I was pregnant, I was like willing to go to prison, and my life is not perfect today by any means, but it is way better than I deserve. That's all I got.
Thank you very much. We had the opportunity to hear the story at our task force meeting, and I think from public health over the past couple years, we have a tendency to focus just on the data. But one of the things that's really resonated with public health over the past couple of years is focusing on storytelling and getting that story across, that recovery is possible and that recovery is beautiful, and that really showing that this illness can be overcome with the community, with the support of individuals like you, individuals that are in the task force. I think it's just unfortunate these days that the deaths, the fatalities are so overwhelming. That's what you see in the news media. But it's stories like these that I think we need to talk about. For those of you that were in attendance last week, there were some people that really shared their own personal stories that have never shared their personal stories with individuals in the open before. And that's powerful to be able to stand up and say that. That's stigma busting, that's stigma breaking, when you can openly talk about something that in the past you wanted to keep underneath the table. So our next speaker is Dr. Minnes. But one of the things that I really want to talk about too is I know that we see the opioid crisis in the paper. Addiction plays a pretty pivotal role in a lot of the things that we deal with in regards to Cuyahoga County. And one of the most interesting things that just came out recently from Dr. Gilson's report is a rise in cocaine overdose in August. So what we're going to be hearing today is another drug that has collateral damage in the community that we serve. On the bigger picture of things, I think I mentioned last week, is the overall impact and collateral damage of addiction. That's inclusive of alcohol, cocaine, meth, and opioids. Is it the time that we need to begin to really focus on our country, on addiction as a whole? The Surgeon General is actually going to be coming out this fall with a report exclusively on that issue. So I'm looking forward to this presentation, and hand it off to you.
Thank you very much, everybody hear me, for inviting me. And I have to first say thank you very, very much to my partner panelists. And I am humbled and wondering how I could convey anything as meaningful as she really helped us to understand about mothers who are addicted and become pregnant and what they really go through. I'm going to talk about my experience of coming to Cleveland in the late 80s, early 90s, when many of you will remember that it was the beginning of the crack cocaine epidemic in Cleveland. And as we just heard from Vince, there may be even a resurgence of that going on now, but it was really at its height in the late 80s and 90s. And you probably remember, let's make sure I have this, you probably remember many of the popular magazines. This is Time magazine that had very scary covers on them about this epidemic and what was happening and how many children were being born prenatally exposed to cocaine. And it was very alarming. They were very, very alarmist about what might become of babies who were born to mothers who use cocaine. And it was a very frightening time, and they said a lot of things that they didn't really know because there wasn't research to show what really happened with the moms and the babies. So I just want to show you this next slide, just a little bit about the history. You can see back in this slide that back in the mid, even though it had dropped off from the late 80s, early 90s in 2004, cocaine crack cocaine was the drug of choice. I don't want to say choice, but the drug that was available in Cleveland and that women were using, men and women were using, but there were many women delivering with babies that were born to cocaine. And you can see as we reached around 2010, that changed dramatically and the cocaine dropped off, but that the opiate use of all forms, prescription drugs and heroin, and you talk about fentanyl, had increased dramatically. And this is where we are today with that even increasing past what this chart shows. But now to flash back a little bit, I keep wanting to look back and make sure that I have the right slide at the right time. In response to that crack cocaine epidemic of the 80s, late 80s and 90s, at Rainbow Babies and Children's Hospital, Lynn Singer, who's in the audience and who introduced us, and Bob Kligman began what was called the Center for the Advancement of Mothers and Children. And the idea was to capitalize on the knowledge that women who were addicted to cocaine really wanted to do the best for their babies. They didn't want to be addicted to cocaine, and that after the babies were born, there needed to be some type of support and intervention for the women and their babies together, because they're a pair, they're a team. And what they set up was a clinic that would see the moms and the babies very quickly, like what we have now at Metro, after the babies were born, and provide intensive social work intervention, referrals for treatment, developmental assessment for the children, and more regular postnatal checkups on the baby than they normally would have, and referrals for the babies if they needed it, so that all the eyes were on the family and trying to provide supportive intervention that saw the families as unfortunate situation where the mom was addicted to a drug and became pregnant. And then what happened with the Center for the Advancement of Mothers and Children, it actually moved over to Metro at the point at which we were funded by the National Institute on Drug Abuse to really take a look at the questions that we had. What was really happening with the moms and the babies? Was it really as dire as the magazine, the public press was, making it out to be? And that program, I don't know whether it's still called there's still something like the Center for the Advancement of Mothers and Children that lives in Jennifer Bailit's project and Phil Fragassi Phil Fragassi was helped us to refer the babies that are in our study and engage the moms and saw the kids postnatally, as he still does today with the opiate epidemic. So we had some questions we wanted to look at. I'm not going to give you a lot of data, but the questions were, what really happens to the babies in terms of their health outcomes and their developmental outcomes after exposure to cocaine? What's important to really, and you also alluded to this, is that it's oftentimes not just one drug, but it's very often a number of different drugs. So our cocaine using women also used alcohol, marijuana, and tobacco. So we have to ask the question, what are the effects of these multiple exposures? So it's not just as simple as saying, what's the effect of opiate exposure? In order to look at this in a scientific way, you have to ask about all of them. But we also wanted to know, what about the after care of the baby, the postnatal environment really had impacts, whether they be negative, or what things really could help to create a situation or environment that was most positive for the baby. And we wanted to know, we looked at a group of about 400 mother and baby pairs in our study, and about 200, the mothers used cocaine while they were pregnant, plus alcohol, marijuana, and tobacco. But our control group was a very high-risk control group, so they used alcohol, marijuana, and tobacco, and not cocaine. So we wanted to see, was there anything different about the women who also used cocaine? So these are the same kind of questions we would have if we investigated, opiate-exposed babies and their mom in this similar kind of way. I'm going to skip one slide and go to this one. And it looks a little complicated, but the storyline is that when you ask a question about prenatal drug exposure, you just can't ask about, did the mom use drugs, yes or no? Because it's so much more complicated than that. It's about how much did they use? What other drugs did they use? What trimester did they use? What other kinds of things were going on? Was there stress or violence? Or probably someone will talk about different sexually transmitted diseases that might be rates are higher. We were talking about hepatitis C that Phil was talking to me earlier before we came in here. So those are things that happen prenatally, but then you have to think about what happens postnatally. Do you go to an environment that's warm and loving and sensitive and caring, or a harsh environment? Is the mother still using in that postnatal environment? In our study, it was very important to look at whether the children had been lead poisoned, going to homes that were very poor and had lead paint somewhere that they got. And so those things also can have negative effects on babies. So it's a very complicated picture. And also, when you think about outcomes, you don't just think about, is the baby healthy, not healthy? We think about primary things like, birth weight, prematurity, whether they have neonatal abstinence syndrome. But then we also look at cognitive development, language development, attention. We look at things later on as the kids get into their teenage years, whether they themselves are more likely to experiment with substances. And all of these things go into sort of the final part of this model is what kind of, outcomes do they have as adults and how well they're functioning in society. So the next two slides, I'm not going to go through these, I'll just leave them up, but this gives you a sample of the assessments that we gave to the babies when they came to see us. We saw all the babies and the moms at very shortly after birth for the study, 6 months, 12 months, 2 years, 4 years, 6 years, 9, 10, 11, and 12, 15, 16, or 15 and 17, and we're now seeing the prenatally cocaine-exposed children as emerging adults at age 20. And I did mention Lynn Singer in terms of her being co-director of the Center for the Advancement of Mothers and Children, but she was also the first investigator of this study, and then later I took it on. So I've been with the study since 1994, and with following in the clinic the baby since 1992. So quite a long time. So that's the list of the type of assessments we do for babies. These are ones that we would ask all the moms to report on things like parenting stress, how well they're coping, whether they're still using substances, because all of these things really matter in terms of the child development. They really can make a difference. And we also made referrals and for women and babies who had additional needs. So I think I want to sort of wrap my portion up here so we can move on to Phil and get to our discussion and make sure I'm at the right place. Implications. I want to tell you just a few general things we found about our moms and how things about the moms impacted child development in our study. So the women in our study who used cocaine in addition to other drugs, they had more psychological symptoms than women who just used alcohol, marijuana, and tobacco. And that's important because it's harder to be a parent sometimes when you have, say, for example, if you're suffering with depression or anxiety. And these were symptoms that were greater at birth, but even when we looked at the moms several years after that, we found that they still had elevated levels of symptoms. So that has a really important implication for the kinds of intervention and support and assessment for symptoms postpartum, and not just immediately postpartum, but ongoing in a longer term kind of way. Women who lost custody of their children at birth, they had more psychological distress than even the other cocaine-using moms who didn't lose custody of their babies. They were also, the women who lost custody also were more likely to have been involved in have child abuse or neglect when they were young babies. And that's an important theme, this idea of entry into substance use. It's a high association or correlation between people who enter into substance use and previous histories of abuse or neglect in their own childhood. The issue of fetal growth was an important outcome because we found that cocaine, like heroin, had an effect on restricting growth, interuterine growth. But in addition to that, or on top of that, also the mother's psychological distress had an independent effect on the baby's growth. So I was really happy to hear that your baby was over 8 pounds. That's a really, it's an important thing when we're talking about newborn babies. It's very basic, but very important because it gives us an idea about how much nutrition the babies are getting and how they've been taken care of. We found that women who use cocaine had more difficulty with mother-child interaction. They were less sensitive and less responsive to their baby's cues. And that's really very important because that's very early stages, setting the very early stages for baby's attention and memory. So these interactions are very important, and we need to keep that as being an important aspect of aftercare or postnatal care. We know that babies, that there are other cognitive and language outcomes that are affected by maternal psychological distress, as well as behavioral outcomes. So taking care of moms in this setting and in this dyad is extremely important for the care of the baby long term. And I think that's really the message that I want to wrap up with. I think I said wrap up before, but not quite. I want to say that this is really how babies do is multi-determined. It's not just did their mother use a drug like cocaine, yes or no? It's multi-determined. It has a lot of different factors that have to be considered. And these can be very variable and heterogeneous, a lot of heterogeneity across mothers. So we don't want to make a lot of assumptions about what happens to babies. We also know that the caregiving environment postnatally is critically important. And very much linked to whether or not the mother continues to get treatment for her substance use problem. And even though we found this, we have these findings related to prenatal cocaine exposure, I am very confident that these are very important issues that have to do with opiate use, maternal opiate use as well. So, and how the mother is doing with this disease, this addiction, impacts on the environment that she's able to provide for the child and the kind of sensitivity and responsivity that she's able to give a child, which are very closely related to how well the baby and the child develops cognitively and behaviorally in many different aspects. So in terms of clinical implications, I would just say, and hopefully we'll talk a little bit more about this, great need for ongoing assessment prenatally, immediately postnatally, and then absolutely through the first year, and I would say probably much beyond the first year, to provide the kind of support and intervention. Ongoing evaluation about the family functioning, particularly family violence, ongoing substance use, have depression or psychological distress, and other kinds of things that can impact women who are affected by substance addiction. Specialized treatment that focuses on the special needs of women and mothers is critically important. Parenting support in many different forms about the development of realistic expectations for babies at different stages of development, different ways of coping with the problems and difficulties that babies give to all new mothers. But specialized with the idea that coping while you're also coping with being a new mom and coping with leading a sober lifestyle is really very important. Specialized training for child welfare workers, foster and adoptive parents in the cases where children are separated from their biologic moms, potentially pre-adoption counseling for families who may be making a decision whether or not to adopt a baby that may be in the system and available for adoption. And early intervention, early assessment and intervention for children who might be at higher risk for learning learning difficulties and behavioral difficulties. So I will end it there and pass it on.
Thank you very much. I think one of the things that, after looking at your slide presentation that was sent to me earlier today, but just some of the complexities of the support networks are there. I happened to see something, it came across the email the other day, that Erie County was the first county that actually has a recovery community for pregnant moms that would accept moms and their children. And I think in the article it said it was the only one in Ohio.
There are others.
Are there others? Okay, so it did say that in the article, but there are others. But I think that one of the things that we continually hear, some of the gaps in the system, are those recovery homes to help, and the lack of recovery homes that are out there. So I think that's really important, but thank you very much. Our next speaker, Phil, I've had the opportunity to interact with him a couple times, and he always brings a very positive a sense about him. And it was funny today, I haven't seen him in quite some time, but as he pulled up in his Jeep and I saw the hat and he came in, it's just it's good to see you again, and I look forward to hearing your presentation. Like I said, you always you come across with a lot of energy, and it's good to see you again. So I'll turn it over to you.
Well, thanks. My name's Phil Fragassi, and I'm a pediatrician at Metro. And I'm going off topic. I prepared something, but I'm going off topic, sorry. I tell my kids all the time that being brave doesn't mean not being afraid. Being brave is doing it even though you are afraid. And that's what I see in my moms, and that's why I love this program. I had a, I'm sorry, I'm going to get all choked up myself. I had a brother who died of this disease at age 32, and which prompted me to get into recovery myself. And I don't tell many people this, but it's going to be 29 years for me this year. And this is why I have such a passion for this, because there's such a misconception about what recovery is. And there's so many people who say, well, nobody's getting better, nobody's getting better. Well, I tell my medical students and my residents, it's because you don't see the ones that are getting better. They're not coming into the emergency room every night with going through withdrawal or with blah, blah, blah. There's millions of us out there. And there is a lot of hope. There's a lot of hope. And I'm so proud to be part of your life and your kids' life. So one of the things I hear moms say all the time is, I'm really trying. And most of these moms aren't trying, they're doing it. And that's really, really, really important. So my oldest NAS baby, I see right now with the MOMS program, I see the majority of the babies that are born that go through neonatal abstinence I see in my clinic. My oldest one now is just graduating from college. So when I was a resident at Rainbow, I saw one of my very first ones that I met in the NICU. And so there's a lot that happens. So I wanted to talk quickly about just the addicted brain. How does this work? There you go. So why opiates? We were talking about cocaine and why is it today opiates? One of the things that we could talk about possibly is that the opiate prescriptions have gone up from 76 million in 1991 to 210 million in 2013. So because of the increase of opiate prescriptions that are being done, people get cut off, they turn to heroin. 9.4% of the population live with some sort of substance abuse and dependence. And any kind of opiate can trigger a latent chronic addiction brain disease. So you may not have been using, but you get opiates for a back pain or whatever, and it can trigger your brain. So I wanted to talk a little bit about the addicted brain. There are a lot of studies that talk about dopamine and other neurotransmitters. And so if this is a person who isn't an addict, and they get high, they go up here. And then when they come down off their drug, they're here, and they're back to normal. Well, in addicts, dopamine and other neurotransmitters are here. And this is proven to up to a year after they're in recovery, and probably further on. So when they use, they feel normal. And that's why people have such a hard time understanding, why are these people continuing to use? And it's because their brain is different. And so it's kind of like talking to an asthmatic and saying, well, why is he continuing to have an asthma attack? Well, it's because he has asthma. And you don't yell at a kid who has an asthma attack like, what the heck's wrong with you? You're having another asthma attack. But we do. Society still looks at people and say, well, why are you still using? Because it's a disease, and it's part of the disease. So this is my quest in life, is to teach people that this is a disease. This is not a moral issue. And the bottom line says, opiate addiction is federally described as a progressive treatable brain disease. So what do? There's 4 parts I wanted to talk about with the kids. What are the special risks that these babies face? What are our assessment strategies? What is the long-term prognosis? And what is the best care for these children? So we're going to go through each one at a time. The special risks are basically all the comorbidities. You know, it's very hard to tease out the alcohol, the tobacco. Lots of these women live in very unstable housing. There's poor prenatal care. There's prematurity. And one of the things that some of the studies that are showing with developmental outcomes is showing the amount of opiates and or methadone that the mother is on while pregnant can make a difference in the prognosis of the development of the child. The important components of the care for the prenatal exposed children, one of the big ones is obviously the medical issues. One of the ones we're seeing primarily in our kids is hepatitis C. So I'm also working, I'm the medical director of New Directions, which is an adolescent drug and alcohol treatment center where we have women who are not pregnant or having children. But we've only tested 50 kids so far, and 3 of them have been positive. I mean, that's a huge percentage. And as we're seeing in our methadone exposed or opiate heroin exposed moms, after 3 months, it's almost an 80% seroconversion rate. About 60 to 70. So the medical issues obviously is one of the things that we're going to work on our assessment strategies, but we also have to do an assessment of the maternal recovery and mental health. That's why it's so important, and you know, Mansi has been so great with working with me when every one of my patients come in. If they don't show up, she will call, find out, make sure everything is going okay, because it's a very transient life. Some of these families are blessed to stay with their kids, and some of them have relapse problems and they go into foster care. So it's very important that we keep up on the assessment of the maternal recovery and mental health. Follow-up is important, and of course we have to work with community resources. So then the big question comes, what about the long-term prognosis? And unfortunately, longitudinal studies of prenatal opiate exposures have not produced consistent finding with regards to developmental sequelae. And I think a lot of that is because there's not been a lot of studies done about it yet. There are some that are out there, and there's some in Maine that show some, and which I'll talk about in a little bit. But it says that developmental scores tend to be lower in exposed infants, but these differences no longer exist when you appropriate medical environmental controls. So it's still very hard to tease out, and we don't have a study like with the cocaine where we have the controls that have all the other comorbid conditions and not the heroin. But some of the stuff that we do have is that there is some very limited data on long-term outcomes, but there is possible delays in general cognitive function, anxiety, aggression, and there's a large difference in outcomes depending on whether alcohol was used. And that's one of the things that the study in Maine really showed. If you tease out the mothers who used alcohol versus the ones that just use heroin, the developmental outcomes are very different.
Can I just chime in?
Sure.
Point of view, I will take a mom on heroin all day long over a mom on cocaine. And here's why. Cocaine can cause something called an abruption, where the placenta comes off and you can bleed to death in about 5 minutes. And when I was a resident in the 90s in big cities, we routinely on any given night would have women come in just dripping with blood. And the babies would die and the mothers would get multiple blood transfusions, and it's a hot mess. Heroin, if you survive it, if you don't overdose, at least doesn't go down in a blaze of glory like that, right? It's not gonna kill you because you bleed to death. So I sort of joke with my moms. I was like, if you're gonna pick something, I'd rather have you on the heroin than the cocaine. I prefer you off everything, but the cocaine in pregnancy is just lethal.
And I always tell my moms, I would much rather have you on heroin than alcohol, because developmental, I mean, we know of alcohol, you know, of fetal alcohol syndrome. And now it's kind of like the autism. Now it's fetal alcohol effects, because there's the full-blown fetal alcohol syndrome, which has, you know, long philtrum and cardiac defects and blah, 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 and developmental delays. But then there's some effects from just any use in alcohol, whereas heroin, it's not so cut and dry. So cocaine and alcohol are not fun either. We can safely say that. One of the studies in Maine showed that at 9 months of age, the only thing that they saw in the first year of life was decreased motor or significant motor delays, but it was mostly in sitting and crawling. So at 9 months, they were not sitting and crawling as well as the controls. But by a year, most of these motor delays did go away. Though some studies show that they may persist, causing attention problems, but we're not really sure. So, bottom line, and I know you probably wanted to ask questions, so my thing is always, addiction is a disease, not a moral issue, and this is why I talk about this here and on NPR and everywhere else, because we're all getting burned out with this. And you hear nurses and doctors and other people say, I'm just tired of this. But we're not tired of kids with asthma. I mean, there's going to be kids with asthma tomorrow and the year after, and there's going to be people with addictions tomorrow and the year after. We have to treat this like a disease and not like a moral issue. These infants do require close developmental assessment, because Lynn Singer's work, both with preemies and with the cocaine infants, shows early intervention is key. If you can get these kids and do developmental assessing as soon as possible, get them into early intervention programs, and then the outcomes are much, much better than if you don't. And lastly, follow-up is imperative. That's why I love the KMAC program, and that's why I love this MOMS program, because when I have 27 patients on my schedule and 5 people don't show up, I don't have time to be calling them. But we have the luxury in some of these studies that I have help. I know which moms are the highest of risk, and if they don't show up, we can call and make sure they're okay. And that's where we need to spend a lot of our time. So thanks for listening.
Did you want to say something?
I just want to say how important it is, because some of our moms, especially if they're in recovery, they want a clean start, and they won't tell their pediatricians. And they'll try to go under the radar screen. And how important it is to have a pediatrician like Dr. Fragassi, where you can be honest, you can say when you're having cravings, you can talk about what you need. He knows how to get mom help as well. And so having that resource is just a godsend for us.
I think we have plenty of time for some questions, so I'll read what I received right now. But what I'm going to start off is actually reading through these. Elizabeth, the first one that came, it's actually for you. It says, you deserve your baby, and he deserves you, and I wish you a successful life together. So once again, a round of applause, please. I think it takes a lot of courage to come up on stage. But this question goes to probably everybody. How long does Child Protective Services stay involved with the mother and the baby, and what are the basic support? What basic support do they provide to the mom to better enable them to remain together?
I'm going to call Monsi out of the audience, 'cause she's our social worker.
Child Services can stay involved from anywhere from 1 month to a year. We depend case by case basis. We really recommend at least 2 months. It also depends on the severity of the mother. If mom got clean at 8 weeks pregnant versus 32 weeks pregnant, obviously they're going to stay involved longer. They do help with housing. They link them to resources. They're a lot more supportive. I know the perception is Children's Services take babies away. You'd be surprised. There are mothers that are really just getting on their feet, and from a legal standpoint, if mom is sober, mom typically gets baby. So that's why we recommend that they stay involved for like 3 to 6 months to make sure that they maintain their sobriety.
And I do have a fair amount of moms who've been sober for years, and we're just still are on the Suboxone or methadone, so the child may still go through withdrawal, and county is involved very short time with them if they've been in recovery for years. But there's just a quick checkup, make sure everything is going okay.
Thank you. The next question is, where do you believe we could enact more beneficial interventions when it comes to mothers with addiction, and specifically pregnant mothers? And I think all 3 of you have experience that could answer this.
Yeah, I think there are a couple things I would like to see. You talked about sort of sober houses. I know of at least 2 in the city that will keep a pregnant woman and allow her to bring her children back. I think maybe 3 if I count Mount Talbot. Yeah. There may be more that I'm less aware of. Bed space is still hard, so it'd be nice to have more. Many of the sober housing and sober living in Cleveland especially believes in the 12 steps and not in buprenorphine or methadone, and so it becomes, they won't take our pregnant women on those adjunct medications, which is too bad. So I think more housing. I think having more doctors who will give buprenorphine in a variety of settings would be helpful. this is a real pie in the sky wish list, but Narcotics Anonymous is full of drug dealers, and they prey on the people who come and hit them up afterwards. I would really love to see a truly sober, perhaps even searched at the door kind of meeting, so that the dealers don't infiltrate the NA. I think that would be very helpful.
This is just something anecdotally that I hear is in terms of the homes, the sober homes, they really need to be adequately funded so that people can stay the length of time that they really need to stay. It's a lengthy process, it's ongoing, and I guess I would just add that part in terms of the attention to and the real payoff for the investment in those sober homes that are truly well run and allow people to stay there for the length of time that it may really take.
Elizabeth, I'm kind of curious what your answer would be to that.
I was lucky enough to go to my mom's house, but I kind of agree with you with the housing because most people look at Suboxone or Subutex, whatever, methadone, as you're not sober, and I believe that too. I believe that too before I got pregnant because I didn't want to be on Subutex. I believe that wasn't sober, but recovery is not black and white. It's not. And my sponsor used to tell me that all the time, and I was like, whatever. But it's not. It's not a one path. Like, some people need extra help. So I agree that with the housing, absolutely.
And this may not have anything to do with the mom's part of this, but I just talked to Manzi yesterday or the day before. We have nothing for teenagers. There's no programs that will do, except in Akron. We have a person in Akron who will do Suboxone, but for anybody under 18 who needs assistance with recovery, we have nothing in Cuyahoga County. Nothing. And these kids are going into treatment and relapsing because they're not on any, because you are sober when you're on Suboxone. You are sober when you're on methadone. I don't care what anybody says. They're wrong.
I think that
It is black and white. You're sober if you're on Suboxone and not using heroin. I'm sorry, it's black and white. If you're not using an illegal substance and you're not using a drug that is not prescribed to you, you are sober.
I think one of the things that's interesting, and we've had some conversations at our task force meetings, is how do you, with all the different properties that are available, it seems like these days, in the county land bank, you see different houses for domestic violence, for special populations or homeless. Is there a way the county, we're looking for things and how we can help. Is there a better way to offer some of these properties that are still inhabitable for the recovery community at a lower cost? We do some things with the childhood lead poisoning. We work with different contractors. Can we find a unique way to maybe offer some more recovery housing for those agencies that want to expand their services? Because that's the one thing that I can tell you, one of the gaps that we continually hear, there's just not enough space. There's not enough treatment. And for those individuals that come to mind that are part of our coalition that are running recovery houses for women, I think it's fantastic, the services that they offer, and we're trying to bridge some services with our Title X nurses, offering reproductive health programming to many of these recovery homes that don't have the connection with physicians, and it's worked out relatively well.
So Metro Health would love to put one together. We're looking for an angel donor if anybody's interested. I can give you the price tag later. But it's one of the things we're exploring, but it is expensive to put together for all the reasons you've just talked about. So we are looking for donors.
It was interesting. Erin Helms, who runs the Woodrow House, I remember getting a call 2 years ago from her mom, and she's like, listen, my daughter wanted to come up to your meeting, but she's in Columbus getting this permit. So you do find these individuals that really put a lot of effort into it, and I think she's looking to purchase another house on the west side.
I just want to put a plug in before I forget. So one of the other things our moms often need is just basic baby supplies, a car seat, a crib, those kinds of things. And Metro holds once a year something we call it the Citywide Baby Shower. I believe it's November 5th this year. And we do take donations, and essentially we set it up, and our moms who are in our program or who are recent graduates of our program can come get clothes and pack and plays and diapers and all the kinds of things that we need that are expensive even when you're getting public support.
This probably would go to everybody up on the panel too. Much of the opioid epidemic has been, it looks like it says, blamed on overprescribing of pain medication. So why is there an increase in cocaine use and I can't. I think it says any information on this.
I'm going to take a crack at that. Because cocaine dealers like the business. So what happens is if you're hooked on heroin, you've got lots of choices in Cleveland. It's like shopping for a sweater. You can get a blue sweater, you can get a red sweater, you can get a yellow sweater. All the dealers are a little bit different. And if they can make their stuff a little stronger or a little better, or you like their stuff better, you'll come back to them again and again and again. There's a lot of money to be made. And people like the way they feel on heroin and cocaine. It's called speedballing. John Belushi died of it. It's a thing. And so when they mix it together, it gets more repeat customers. That's my just economics.
Was your crack at it? I like that.
Yeah. That was not intentional.
No
pun intended.
I think the question may point to the point that you raised, that you just recent reports of people the overdoses. And again, it's because people are, the other part of that is not just using at the same time, but also when you can't get heroin or an opiate and you're feeling really, really terrible, people look around for different kinds of things to come down more easily.
And I shared with everybody last week, Dr. Collins from Metro Hospital, at a meeting with him a couple weeks ago, and he sent out a blast to, and I think the terminology used, it's other individuals that are medical directors in other communities. And it was interesting to hear from other medical directors across the United States that they haven't seen the heroin yet, but on the tagline on the bottom is, we know it's coming. Meth was still their choice in some cases. So the complexities, and it's interesting to be involved in this for so long, where we saw that transition to pill abuse. We tried to put some clamps on that, the shift to heroin, and now with fentanyl. And you see some areas of the country where I'm getting calls where we're still dealing with the pills. What have you guys put in place to try to prevent the fatalities associated with fentanyl and opioids?
And what's interesting to me is, in all my years at Metro, I think I've seen one positive tox screen for methamphetamine. It just doesn't happen. I know the labs are all in Elyria. They're all getting busted out in Lorain County, but we're just not seeing it in Cuyahoga County.
I think this question is in regards to your programming. It says, how do you find out about the women's drug use? Do they tell you? Is everyone tested?
So we do not do universal testing. Pretty much if you find your way to my clinic, you've asked for help from somebody in Cleveland and they've sent you to our clinics. It's not just, and I shouldn't say my clinics, it's me and all my partners, because it's way more than one person can do right now. So if you go to pretty much any place and you want to detox, you want to get sober immediately, they'll say you can't do that during pregnancy, or sometimes they go to detox, they find out they're pregnant and they get sent to Metro. If you get arrested and you're a heroin addict and you're pregnant, you get sent to Metro. And every once in a while, like I had a patient the other day who came to me for quote unquote hypertension, and by the time I was done questioning her, she turned out to be a heroin addict. Mostly they tell us. Every once in a while, I'll have a savvy doc notice the tracks and say, you need to go see Dr. Bailit.
Okay. I guess, this, to everybody on the panel through experiences too, what else supports recovery besides the love for your children? Are there other support mechanisms out there that have worked to influence or to help somebody? Like last week, we had individuals from CASE that talked about family members that have maybe previously used, but now are sober and helping somebody through their recovery.
Family can help or hurt. I've
Right.
seen a lot of families where mom's using, sister's using, cousin's using, and breaking away from that is really hard because you lose your entire family too, or you lose your boyfriend. So families can go both ways. I've also seen, especially grandmas, stick by their daughters and pull them out of the deepest depths, and they're just wonderful. And if it hasn't been for those moms, I don't know what they would have done. So family can go both ways. In terms of other resources, I think some of the recovery groups are quite good, and people really lean on each other. And then I think the other thing that is sort of getting back to the housing is that inpatient recovery, where you get taken out of your usual sandbox and put someplace else into a more quote-unquote normal living environment, a more sober living environment, can also help.
They've done a lot of studies with why the 12-step program has been the most successful. And they've actually done some recent studies with other sober living recovery programs, and the success rate and the recidivism rate is the same. It's not so much. I mean, I love the 12 steps, and it's a great way to live if you listen to it. But it's not the 12 steps that does it. It is the sober recovery and the community and the it's basically group therapy, you know, every week having a place to go where you feel comfortable. And that was the guiding factor in the percentage of recovery. And like you said, though, it has to be a sober recovery. And what's happening is, you know, some of these drug dealers are infiltrating some of these sober recovery places. And it's, if you're in recovery, you know which meetings are good to go to and which meetings are not good to go to. And it is what it is.
Sometimes we use the word social support, but I think those communities that you're talking about give the support, but I think it's almost even a little bit more than that. It's a group of people, network of people that have a real belief in your recovery, a belief that it can happen, and the undying support and understanding of the how hard it is. Exactly. I mean, I think those are just, I think social support minimizes that term
it's
so much.
Like having a pediatrician who supports you. It's really surrounding yourself with people who know and care and can help you.
The thing about AA that is amazing, or any of these sober recoveries, but you can go off on a trip to visit your grandmother in Atlanta, you know, look it up and say, where's the nearest AA meeting? And they may not know you, but you can talk. You can say, holy crap, today was a bad day. Everybody was drinking wine. I wanted something. And it's this greater community that's almost underground and bizarre, but it's everywhere. It's in Europe. You can find recovery if you look for it. I'm too old to know about that. She said there's a lot of online meetings also, but I
only know that because I was too big to be leaving the house towards the end of my pregnancy, so I did online meetings. And if you get active in the program, I knew a lot of people previous to being pregnant, but if you get active in the program early in your recovery, I mean, people will come to your house and do a meeting in your house. Like, AA is, it's family. I mean, like, they become I'm closer to people in AA probably than I am my own family.
Is there any data on addiction of cocaine? I think it says advancing to heroin.
Look at us all look at each other.
I don't know of any right offhand. I mean, there's some data on these gateway drugs like marijuana moving on to other kinds of drugs, but I think what we're seeing probably is more of with those two drugs, a volleying back and forth and availability in your city.
And I also think it's a lot of people self-medicating. We have a ton of patients when they get sober. It turns out they have anxiety disorders. The cocaine folks, when they get sober, tend to be depressed, in my estimation. So they're treating different mental illnesses with different drugs. So there are cocaine predominant people who do both, and there are heroin predominant people who do both, but they're different types of people.
And I just tell people and my kids and medical students, you just can't trust the drug dealers, because you could say you're getting heroin, but if they want you to get hooked on cocaine, they'll just add that, and then suddenly you're hooked on cocaine. So I mean, when people come into the emergency room and the girlfriend says, I swear to God, all he did was cocaine and he has a low heart rate, you better give that guy some Narcan, because I don't care what they said they took. You treat them, you don't know. Drug dealers lie.
They're labeling laws with the dealers.
Right.
Yeah, that's been a big challenge. I mean, for dealing with the Department of Justice, some of the things that they've shared for our subcommittee meetings. I know there's a gentleman in Euclid that was selling blue Oxycontins that were pure fentanyl, and we hear that quite a bit. But it gets into some of the things too, as far as do you put information out there that tells people that there's bad product on the street? Some people think that it draws attention to that, and more people go to that. And how do you put that message out there? If you're going to use safely, it's. Well,
it's interesting because when I talk to some of my patients, and they'll say, yeah, when they say everybody's dying in Akron, the first thing we do is get in the car and go to Akron, because that means it's going to be a better high. So they're chasing the dragon. I mean, they're chasing something that they're willing to flirt with death with. So when I talk about safer shooting, I don't necessarily talk about where they go to their dealer, but I may say go to the same dealer every time at least. And then we talk about cleaning skin off, using clean needles. There is needle exchange in Cleveland. We talk about sharing needles. If you have to share, be the first one to use the clean needle and then pass it off to somebody else. I mean, it's all these things you wouldn't think of. If you're on the streets and you're getting the water to cook the heroin with, use running water instead of water from a puddle. I mean, just stuff that's like normal people don't think about, but when you're really in the life, these little things may make a small difference.
And I'm sure you guys have talked about the Project Dawn kits and having people having that available for everybody who could use a Project Dawn kit.
Does everybody in the audience know what a Project Dawn kit is? No? Okay. So, do you want to? The medicine you get when you overdose on an opiate is called Narcan. In the hospital, we stick a needle in you, but it turns out you can spray it up somebody's nose and it works. And so there's a project, a grant program at Metro and now elsewhere where we give out kits of nasal Narcan, and you get 2 doses. It's free. You just need to come and get the education. And the free clinic gives them away. My clinic gives them away. A few other places around town.
Yeah, there's
Where?
The McCafferty Center.
And
The
Board
Board
of
of
Health.
Health, and just recently the Emergency Management Clinical Services in Cleveland does it now.
Okay.
That just started. So if you query Project Dawn, it'll give you the locations. Emily Metz and Joan Papp have done a fantastic work through Metro to get. Yeah, there's different.
You can buy it. The Project Dawn is
pharmacies.
free.
Yeah. And, currently what we're looking at in Cuyahoga County, I think they've trained close to 5,000 individuals, and there's over 500 overdose reversals. They've been instrumental in getting Narcan in the hands of law enforcement also. Since law enforcement, I think in Cuyahoga County, we currently have about 47 of the 59 law enforcement agencies that are actually carrying, and over the past year and a half, they have over 140 reversals also. So it is a life-saving drug. You can't put somebody in treatment if they're not breathing. And, Joan and Emily have done a fantastic job on really putting that effort into Cuyahoga County.
And not only did they do that, but they've changed the law so that families can get it. You don't have to be the addict to get the drug anymore. If you are a concerned parent and you've got a kid who's using and you just want something around the house, you can get it.
Yeah. And I think that the beauty of that, folks, is, people continually ask, what can you do? A lot of the information that came out from our poison death review that recognized that in many cases individuals that were using in the presence of others, some of those being their moms, their dads. Joan was able to take that information down to Representative Sprague as they passed this bill that gave third-party availability of Narcan. And that's been a wonderful change in the number of people that have this drug in their hands now. It's really been a lifesaver for many in Cuyahoga County. This question, this was going to come up, and we talked about it earlier. The recent news photo of the grandmother and father passed out in their car with the 3-year-old in the back seat. Most people's response to that was disdain for the adults. What about changing the thinking to see those adults as how sick they are instead? And I think everybody has mentioned this. I mean, it's an uphill battle with addiction.
What if they both had a heart attack or something? Nobody would be yelling at them for having a heart attack, or if they had, they had a stroke or something. I mean, it's just educating the community that this is a disease, and it's not a moral issue. It's just hard because we're all so impacted by this, and it's such a visceral reaction. And sometimes the disdain is not even so much disdain as despair. Like, what else can we do? And so all we can do is educate, I guess, unless anybody else has anything else.
I shared this last week, from the standpoint of education, the addiction in my family. And I remember my 18-year-old brother going away for armed robbery and for cocaine. And I remember getting the calls from Lebanon State Institution and just hanging up. Hey, collect call from Tony, boom. And I looked at it that way, and having the different side of this now and going into get another master's on clinical therapy and knowing how my mom feels, sometimes it takes that light. And I don't have a relationship with my brother, and I don't know if I ever will. But I look at this differently, and I always share that with individuals in the crowd. When I was down in Atlanta talking to law enforcement when they were developing, I could see the faces in the crowd and these guys, and you just hope it doesn't happen to their family, because it is a family disease. It really, truly is.
There's an audience.
Hey.
So, some of
us here are first-line educators, and what I consistently see is that we are continually calling them addicts. When we really need to rephrase it, we're going to be talking to the public and say, people with substance use disorder. Do we continue to educate the public that this label that is so negative isn't always coming out from our mouths? So I think that might be a place to just rethink how we talk about these people.
Yeah, I think, even Judge Matai had mentioned, instead of calling it drug court, recovery court. I think simple changes like that to change the way that we view this. It's hard. We were talking prior to coming in here just last week, the editorial board of the former plain dealer at cleveland.com, and you looked at some of the responses. Some of the responses were more oriented towards education, and others were like, hey, they made those choices, let them die in their own inferno or something like that. And I think, Dr. Gilson has said it the best sometimes. We're talking about human beings too. When I saw the picture, at first, and then I found out that they didn't even cover up the young boy's face in the back of that car. What are the challenges that that young boy is going to face? Is he going to be bullied? Is he always going to remember that, maybe come down with some type of mental illness that's his stepping stone to addiction? It's hard. I think that there's so much, it's overtaken so many people. People don't know what to do, and we're making knee-jerk reactions and focusing on shame that doesn't seem to have worked for addiction for the past 150 years. It's difficult.
It was the big thing when we had crack kids on the cover of Time magazine. I always said you need to put the child before the disability, or the child before the disease, the person before the disease. It's a person who struggles with this, or it's a child who is exposed to cocaine. And, I've been talking about that since 1994, and we see how it works.
I think those words are extremely powerful. I agree with you that we really have to put the individual and the children. And we're seeing the children in our study who are now emerging adults and having children themselves. And sometimes they talk about, that they may be in foster care, or they know that their mom used cocaine, and that image of yourself in this world can be just very potent. So thank you for bringing that up.
I'm not sure who this question goes to, but it says, you said you don't tell many people you are in recovery, and yet you are surprised people around you are ignorant about the successful recovery. And who the people are with substance abuse struggles. Why are you not verbal, with your story?
Well, I would assume that's directed at me.
Yeah.
Since I'm the only one who came out today. I think part of it is anonymity is the foundation of AA. And the reason anonymity is important is not because I'm ashamed. It's because if I fail, and I start using again, people will say, oh, we'll see. It's a disease that people don't recover from. And I think it's very important. It's what I believe in. So I believe that anonymity is incredibly important to recovery. I think there are times that it is important to share your story, and then I think that there are times, I think most of my moms, I will say things, they know I'm savvy with it. I don't tell them my whole story because I don't need to tell them my whole story. I am not.
The doctor shares that much personal stuff with their patients.
Right. I mean, I do it to my medical students. My medical students know, and I think there's a time and a place to share your story, and there's a time and a place to be a professional.
I think if you're in recovery and you go to see Dr. Fragassi, speaking with him the first time, you would know right away. Just by the things that he says, you would know. When you're talking about recovery, he says we, and I knew right away before he told me, so.
And those of us who work closely with Phil know, but like you said, there's a time to be a professional, and there's a time that you just don't share these things. Not that this was non-professional, don't get me wrong.
Well, it was unscripted, let's say that.
That's all the questions that I received. Does anybody else have any other questions? Just do me a favor, if you could stand up and make sure that the rest of the crowd can hear you, that would be very helpful.
Do you think because this epidemic now is really hitting suburbanites, and it's again, not the typical stereotype that it used to be, more inner cities, that there will eventually be more help?
I think it's interesting. I think, so to your point, the crack epidemic had an inner city profile.
Right, and the old heroin epidemic in the 70s was an inner city thing.
And Vietnam vet thing. And this is all suburban girls who go to Shaker Heights and Beechwood and all the towns around.
For some reason.
Right. So I already think it's getting more attention because it's a suburban and it's touching our legislators and our judges and everybody else's. I think the Project Dawn and their ability to change the legislation is largely because of that. I think there's some legislation going through Washington that would change. It's sort of arcane billing rules for addiction treatment, but they would potentially open up a lot more beds. So I think some of the things are happening faster with heroin than we ever saw with crack cocaine. I think in many ways what happened with crack cocaine had more to do with market forces than any treatment we ever came up with.
I'd really think it's interesting to think about how we responded to women who used cocaine during pregnancy. There were some states that had laws to jail women, and I don't think we see quite as much of that, but we still do see some of that. It's not completely gone. Yeah.
Texas is right there.
Tennessee, I was down at a national conference, and I was shocked at some of the things that they were doing in regards to going cold turkey. And I remember hearing your talk before going down there, and I'm like, I'm not a physician, but that doesn't sound right. But yeah, you good? Any other questions? Well, I'd like to thank everybody. So if we could give a round of applause to the speakers. Would you like to know? Thank you for coming out on such a beautiful night and dealing with the traffic. Thank you for sharing your story again. I do appreciate that. And I remember, last time I saw you, you had the little guy there with you. So I truly mean that. And, I don't know, in closing, for the physicians, I mean, public health, I mentioned this is like one of the most complex things I've ever been involved in my life. And I don't know how you guys feel about that from, the medical standpoint or research standpoint, but it's intriguing. But I think what I really enjoy out is seeing those success stories, and we don't get enough of those success stories in the media. We don't hear about stuff like this, or parents that are taking a tragic event in their life and turning it into a positive, with the work that's going on at your level. And I want to do more of that, but it seems like the media is so focused on if it bleeds, it leads, and how do you make that work? But thank you again for your time. I greatly appreciate it, and thank you.